In today's video, we're talking about Cialis and Viagra. So these are medications that men take in order to get erections. Now, in prostate cancer, it actually works a little differently after treatment. In fact, the definition of erectile dysfunction is no longer being able to get an erection while on Cialis or Viagra. So today we're going to talk to Dr. Mark Scholes, who's a 30-year medical oncologist who's focused solely in prostate cancer, and he's going to talk about how to use these drugs if you've had a prostate cancer treatment and what else you can do in that process. Today we're talking about Cialis and Viagra. So these are common pills that we hear on commercials, and you hear a lot of marketing behind them for men pretty much after the age of 40. However, in the context of prostate cancer, they have a different usage, I would say, and normally when we see these commercials, you hear you take the pill and you're able to typically get an erection without an issue, but when it comes to prostate cancer, especially post-treatment, we're in a completely different world. And I think oftentimes patients are expecting a certain response to the medication, and they're not really sure of why this is going on and why it's not being effective and why there would be something to, more efforts needed in order for that process to happen. So can you, first of all, just explain what Cialis and Viagra are and how they work in the body?
Sure. These are miracle drugs that, in my own career, before these medicines were discovered and marketed, the only way that men could recover erections without some sort of an operation where they put a plastic tube inside the penis was to give an injection at the base of the penis of certain medications that would induce erections. To me, those shots sounded so barbaric that in my own discomfort with talking about things sexual, I just sort of gave it a pass. And that had to change when Viagra first came out because it was a real game changer, very effective, oftentimes would take men who are unable to get erections and be able to perform normally. And lo and behold, I discovered a lot of men were using these shots unbeknownst, and they were so happy with their shots that they said, nah, keep your Viagra, Dr. Scholes. There are layers of treatment beyond Viagra and Cialis, but they're usually a big step for people, and like myself, many patients are uncomfortable with the idea of giving shots. I think it's important for us to talk about this because when men are talking to prostate cancer experts and discussing the possible side effects of surgery or radiation, the incidence of impotence afterwards, which is a very prominent side effect after these treatments, the assumption, I think, often is that the pills will come to the rescue. And that is sometimes true. But in my world, the world of prostate cancer, when we talk about men who have developed erectile dysfunction, we're talking about men who are already taking the pills and still can't get an erection. So that's a different paradigm than what the general public thinks. If I have some trouble getting erections and I'll take a pill and the problem's gone away, that is considered erectile dysfunction. You need a pill to function. But in the prostate cancer world, it's considered erectile dysfunction only if you are already taking the pills and are still unable to get an erection, which is a much more dire situation, usually requiring another level of commitment, learning how to give yourself a shot or perhaps consulting with a surgeon to put a penile prosthesis in. These medicines are, in terms of their functionality, which is what your original question was, work through a biochemical process that just make it easier for men to get erections with relatively minimal visual or romantic stimuli. They do not cause erections in men that are just not interested in sex. And this becomes a real issue, of course, in some of our patients who are taking hormonal medicines, hormonal blocking medicines, that tend to erase sexual desire. And the question then comes up is how much use will these medicines have in men that have no libido?
So we talk about this on our channel quite a bit, but I think defining terms is quite helpful. So can you define the difference between potency and libido?
So libido is the psychological, subjective interest in participating in romantic activity. Sexual desire is libido. The issue of potency has to do with the capacity for a man to get an erection. And the two can be separated. For example, as I mentioned previously, injections can induce an erection in men that has absolutely no interest in participating in sexual activity. So potency can be separate from libido. And of course, people can be desirous and unable to get an erection. Again, libido and potency are two distinct things.
So we've talked about, taking these medications in hormone therapy patients, but let's go back to like surgery and radiation. You said that sometimes men are able to get erections after surgery or radiation with these medications. So with surgery, what's the likelihood? Is it like, 1/3 of men will probably get it back?
There's a lot of factors. It depends on a man's function prior to surgery. It depends on the quality and the skill of the surgeons. And then there are other factors that are unclear. But if you take the very finest surgeons and you take a man who has optimal function, and age is certainly relevant. So let's say a 60-year-old optimal function, not using any pills prior to surgery, and undergoing surgery with a world-class surgeon. How many of those men will have some sort of functionality afterwards with the use of pills? It would probably be about somewhere between 50% to 66, or half of the men, or maybe 2/3 of the men, will have some sort of functionality. World-class surgeon, perfect function prior, 60 years old. Those numbers are going to deteriorate in men that get older, men that have some impairment prior to surgery, and of course in men that have surgeons that are not world-class.
What about in terms of radiation?
I would generalize that using the exact same profile of patient, that you're going to get about a 50% better likelihood of having functional erections with radiation than with surgery. So let's work backwards. How many men are going to be totally devastated where they can take pills and have no function at all? With that same profile patient, a 60-year-old, good function prior, it's probably going to be about 40%. And I would say in men undergoing radiation, have the exact same profile, it would be about 20% of men are going to be flatlined at age 60 with radiation.
Before I get to my next question, there's 3 things I want to remind you about. Next September, we're having an in-person conference for prostate cancer patients and their families. It's a great way to get your questions answered, and you can learn more at pcri.org/conference. Now, please click that subscribe button, because when you subscribe to our channel, it pushes our videos out to other people who need them. And if you would like to donate and join our cause, you can do so at pcri.org/donate. Now back to my conversation with Dr. Schulz. One of the things that I find is often not talked about is what can men do before treatment? So if you start Cialis or Viagra before treatment, would it be more likely that you'd be able to maintain some function afterwards because you've already started that process, your body's used to it, and you're getting those erections?
The studies on this are not super precise, but there is sort of a logical argument for starting these medications before treatment and continuing them through treatment. The strongest arguments, I think, are in men that are having surgery and the men who have radiation plus hormone treatment. Both of those types of treatment create a holiday period from erections in men. Men are normally getting erections at night, so-called nocturnal erections. Think of it as God's exercise program. And that goes away after surgery, and it usually disappears also in men who are on hormone therapy. Atrophy or disuse of the muscles that cause erections inside the penis can cause atrophy, and that is a contributor to lower recovery rates after the hormone therapy stops or after the shock of surgery wears off. The shock of surgery can last anywhere from 6 to 18 months. Use of medications in the interim is one way to try and combat that problem. I think it's only a partial fix, because a lot of men, despite the use of medicines, are still not going to get erections. I think it will help some men, and it's a logical thing to implement. As I mentioned earlier, the use of injection therapy can induce an erection 100% of the time. And to implement that early on after treatment and during that time when the nighttime erections have disappeared is a prudent policy. Studies have shown that the men that implement injection therapy right after surgery have higher recovery rates of normal erections compared to the men that don't do that.
Yeah, and I think in John Mulhall's talk, it said like 6 weeks afterwards you can start injecting yourself, which is, I think, when you think you have surgery and then you're going to start injecting something, you would think it'd be a lot farther down the line, but I don't think men realize it's that early according to the trials.
Yes, and this is not talked about. I mean, the surgeons and the radiation therapists are kind of competing with each other, and they're coming up with arguments of why to do surgery and why to do radiation. It doesn't often come up that the optimization of keeping sexual function, keeping erections, and attacked could involve you having to give yourself an injection in the penis starting, I wouldn't even wait 6 weeks. I would start right after surgery, is a very unattractive proposition. If someone says, well, wait a minute, if I just did radiation and if I'm able to do the radiation without any hormone treatment, then I don't have to go through a period of shock or having a downtime, and I wouldn't have to give myself injections in the penis. As surgeons present, why you should do surgery, the optimization of sexual function after surgery doesn't come up for discussion because the solution doesn't sound very attractive if you're going to have to be giving yourself shots.
So is it an automatic that men who are on hormone therapy and have had previous treatment will not respond to Cialis and Viagra because it's the compound of the treatment and not being interested in sexual activity?
You would think that would be the case. When Viagra first came out, we had a number of men that were on hormone treatment, and so we did an informal study where we would prescribe these men Viagra pills, and the question is, will you be able to get an erection with the use of Viagra, despite the fact your libido is low? And it was sort of humorous because when we would see the patients in the office, we would give them a prescription for it and see them the following month, and it was like, oh, I forgot to take the pill. There was really no motivation. So we were so interested to discover whether or not it would work that we took, Dr. Lem, my partner, and myself took to calling the patients at home, say, tonight's the night you're going to take the Viagra pill. And the answer often was, well, I'll take one for the team, Dr. Scholes. Lo and behold, about half of the men were able to get erections. Most were unable to get excited enough to have orgasms. A few even achieved orgasms, but a good 50% were able indeed to get erections with Viagra with essentially no libido.
So what about side effects from these medications? Are there side effects that would be greatly affecting any quality of life if you're going to continue to take these?
Viagra and Cialis are a little bit different because Cialis is given on a daily basis. Viagra is given, an hour to a couple hours before sexual activity. Side effects are usually not prominent. They were originally studied as blood pressure pills, so it is possible to get a little bit lightheaded. Viagra can cause some blue hue to the way your eyes view reality. Some people can get vascular headaches because it relaxes the blood vessels. It can create a problem. Others complain of if your blood vessels in your sinuses dilate, you can get kind of a stuffy nose from it. Usually not a big deal. A lot of people can take them really with no side effects whatsoever.
So when we think of Cialis or Viagra, we typically think of them in sexual terms, but what about in urinary terms? Are there any benefits or minuses to these medications?
Yeah, so after Cialis was FDA approved for correcting erectile dysfunction, it was discovered that men were reporting an improvement in urine flows along the lines of what is accomplished with alpha blockers like Flomax or Rapaflo or uroxetrol. Manufacturer then went back to the FDA and got an approval for using Cialis in that role as well. And it is a popular alternative to Flomax because Flomax, while it's very effective, sometimes causes something called retrograde ejaculation. The prostate relaxes so much when the man has an orgasm, the semen goes backwards instead of out the end of the penis. Also, because Flomax relaxes blood vessels, it can cause some dizziness or lightheadedness if the blood pressure drops too much. Cialis can be an alternative to Flomax or Rapaflo or uroxetrol because it's less commonly associated with those side effects.
I know we're talking about Cialis and Viagra in the context of treatment, but we have a lot of men who watch this channel that are active surveillance patients, and a lot of them are dealing with BPH issues. Is there any sort of benefits or minuses to taking Cialis and Viagra in the terms of being a Gleason 6 patient with a large prostate?
Potentially benefits for the reasons we've covered because of the enhancement to urinary flow, which is often impeded by men with big prostates or weakened bladders from age. Cialis is quite popular for this utilization, aside from its known benefits for restoring erections.
One of the talks I would encourage you to watch, and I'll link it in the comment section below this video, is by a doctor named Jeff Brady. He's with Advent Health, but he did a recent talk at our September conference that was on ED, and urinary issues. And he talked about what to do if you need to move forward in your healthcare when it comes to erections, and making sure that you know what procedures can be done, what pills can be done, what injections can be done, vacuum pumps, and so on. And he even talks about some interesting treatments if you've had damage to those areas on what they can do to fix it, because he is a reconstructive urologic surgeon. It's a very interesting talk, and I would really encourage you to watch it. Now, if you have questions about anything we talked about when it comes to Cialis and Viagra and what to do post-treatment or pre-treatment, I would reach out to our helpline at pcri.org/helpline, because these men have been through this process. They are prostate cancer patients who have had issues with these areas, and they know a lot about it. They've been trained by our medical oncology team, and they can help get you ready for your next doctor's appointment. They could talk to you about various options to ask him about and kind of walk through that whole process with you. Now, I would encourage you, one of the things that I see oftentimes in these situations is that men don't speak up about their issues because it is of quite a sensitive nature, and we see this across the board in prostate cancer, but I really believe you're so important. You as a human being have lived with a certain function for your entire life so far. And, just because you have prostate cancer doesn't mean it should go by the wayside. The quality of life, even in those areas, really matters. I want you to speak up for yourself. I want you to ask questions. And maybe you're not comfortable asking certain people about it, but other people you are more comfortable. Maybe a support group's right for you, or calling helpline because it's a private conversation and they can help get you ready emotionally or mentally to have that conversation with your doctor. Maybe sometimes it's even not bringing a caregiver with you and just asking the doctor directly because you don't want to talk about it in front of them. I would encourage you to do whatever it takes to make you feel comfortable through that process so that you can get the care you need. I don't like that men oftentimes suffer in silence and then are left with consequences because of treatment, and then don't know what their options are because they really have never asked. So I would encourage you, speak up for yourself. You're important, as I've said, but you're also not alone. There's a lot of resources out there, not just on the PCRI website or our YouTube channel or the helpline, but there's other advocacy groups, which we'll also link in the description below. The support groups, as I mentioned, are also kind of a great place if you want to find somebody who you think knows a bit about this information, like the support group leader, and can also help guide you through that process locally. It is important to make sure that you're getting the mental health, the emotional health, the spiritual health support that you need as you walk through this process. Again, fighting prostate cancer is one battle by itself, but losing what's normal to you and your function and how you think of yourself and your confidence and all of that is something that we would hopefully help eliminate through all of these resources to whatever extent we can, because we want to make sure that you're taking care of you. Please remember, most of all, you're not alone, and I hope you have a great week.